My first guest is Dr. Lori Halton. You are a breast radiologist with Baptist Health.
Yes, I am.
All right, now we usually do this breast awareness month during breast cancer. We talk about mammograms. We do this once a year, and it seems like every year the target changes on who gets a mammogram. Tell us what it is now. What's the recommendation?
Currently, recommendations are that you start screening at age 40. That's by the Society of Breast Imaging, the American College of Radiology, American College of Obstetrics and Gynecology, starting at age 40 and once a year, and that will be the way to detect the most breast cancers.
How long do you screen, and how often do you screen?
There's not really a set end date. We have data that goes through age 75, but basically as long as you're expected to have 5 to 10 years of good life to live, we would say to continue screening, but obviously it's a personal choice.
Every year, every other year, every 5 years?
Every year.
So mammogram is the way you screen. Is a mammogram, or you hear the term 3D? Is there a difference?
There's a difference. There are digital mammograms, which are just basically a 2D picture, 4 views, but tomosynthesis, or what we call a 3D mammogram, is actually where it takes multiple slices through the breast, which is very helpful because one of the biggest things that makes mammograms hard to read are the overlapping tissue. So when we can scroll through and look through the tissue, it helps us find small masses, areas of distortion, and those things can be signs of cancer.
So not everybody, well, I guess everybody ought to get a mammogram, but not everybody needs an MRI or an ultrasound. Who are candidates for that, and why would you do that?
We use ultrasound, particularly at Baptist. It's often a diagnostic tool. So if someone comes in with a palpable finding, say a lump in their breast, it's a very great tool to look for palpable findings. We use it if we see something on the mammogram ultrasound to see if we can find a correlate, because that way we could do a biopsy under ultrasound guidance. MRI is probably one of our most robust screening tools. The combination actually of that and a mammogram would yield the highest cancer detection rate. That would be, though, for people that are considered high risk. Women whose lifetime risk is 20% or greater. And that can be calculated by multiple lifetime risk assessment tools, which actually can be something that you can bring up with your family practice doctor.
So if you are at high risk, there's more things you can do than just a mammogram.
Yeah, if you're considered high risk, we would recommend potentially meeting with someone in genetics, because not only will we potentially recommend a mammogram and an MRI, but you could also have some genetic testing, because some people are known carriers of, say, the BRCA gene, which we've heard about before. I think Angelina Jolie, the actress, made that pretty much well known. And some people can be maybe even need chemo prevention, and they can actually see an oncologist. So there's lots of other things that we can do for people who are at high risk.
Now, if you have an abnormality or an overlapping shadow, or you don't get a good view, a lot of women will get what I call callbacks. A lot of my patients say, oh, I've got a letter, I need another view. And they sometimes tend to panic, but most callbacks doesn't mean you've got something bad.
No. And I think that's one of the things we want to reduce the anxiety surrounding the callback, because, roughly speaking, all callbacks, 80% are fine, and it can be resolved with just a couple pictures. Or maybe an ultrasound. 20% of those may require biopsy, but the vast majority of biopsies are benign. Say 80% of biopsies can be benign. So I think we want to take away a lot of the anxiety and the fear, because in many cases it was resolved and then you can leave with peace of mind. And when you come for your diagnostic, you have answers that day. So we'll let you know if you'll need a biopsy, if not. So, and most of the time it's fine.
Well, let's talk a little bit about biopsy, since you bring that up. If you've gone through the whole process and there's really a concern there, you also do breast biopsies.
We do. We do several types of biopsies, like I mentioned before, ultrasound-guided biopsies, where we use an ultrasound probe, lots of numbing medicine, a small needle, or sometimes we use the mammogram to guide us to do a biopsy. So there's something called a stereotactic biopsy. A lot of times we do that for small microcalcifications, which can be a sign of very early cancer. Areas of pulling or architectural distortion also can be a sign of cancer. That one would be done where you can actually either lay on a table or sit upright. Again, small needles, lots of numbing medicine. We can actually even do a biopsy with the MRI magnet, not while you're in the tube, but we'd obviously bring you out and then do the biopsy. But those, areas of enhancement that we see in MRI can sometimes be cancers that we can't see in any other modality. So it's a very helpful tool to be used for people who are at high risk, and just a very strong way to find small cancers.
Well, that's great information. Thanks for coming in and sharing with us. And at Breast Cancer Awareness Month, if you haven't had your mammogram, talk to your doctor.